I I thought it would be nice because I remember when I was early in my career trying to think about my life, hearing some people who figured out at least a career that they enjoyed, talking about how they got there. And then I'll focus a little bit on global blindness in this talk because I think that's an area, particularly your generation of tremendous interest. I was born in a very optimistic time. It was the '60s when I was born, and the '70s when I grew up, which was kind of post Vietnam, and I think everybody felt like contributing to the world in a meaningful way was a big part of kind of the reason for doing things. At least I did. My father was the first to go to college in his family, but he was a surgeon, and I felt that I'd been provided a very privileged opportunity to go to a really good high school, which was a public school, but a very good one. And then I honestly felt that there was a fair amount of luck and hard work, but I got to Yale and then Harvard Med, and always felt along the way that I really had more than I deserved in some way. And so I was very interested in global development and thought that's how I'd spend my life. And I went and I studied Chinese while I was at Yale, and I was an East Asian Studies major. I was not pre-med. And I really wanted to, help people who had a lot less than we did in the United States. And so I spent time, Jacob, if you could mute your phone. And I spent a lot of time trying to, figure out how I could maybe help with foreign service, development, political type things. And then I spent a year in China, and it was not that far after the Cultural Revolution. I was part of a high school group that went in 1980, which was right after the country opened up, and there were still women with bound feet. It was just an unbelievable time. The poverty there was pretty extreme, and I really got to know people who had suffered during the Cultural Revolution and people who had caused suffering during the Cultural Revolution. They felt very badly about how they behaved in believing that they were doing the right thing, and it really made me question my own desires, because I didn't want to wake up at the end of 20 years of work and say, why did I do what I did? And had I harmed a lot of people? And were those bad decisions? What motivated me? And, I'd never really wanted to be a doctor, but then, my dad was doing really interesting things and it seemed like not such a bad thing to go into. And so I decided I'd go to med school, and I spent my senior year taking calculus and physics and all the things I hadn't taken. Then I spent another year, not as a postbac, but as a student, just finishing up the core requirements. And I applied to med school. And I actually spent a year after applying to med school and getting in, going to live in Taiwan and finish my Chinese skills, because I was really still very interested in being able to speak Chinese well, and I didn't want to abandon that at that time. And part of what I would say there, and I think you guys know that more in your era, is you don't have to rush into any career right away. Like, I took an extra year, so I was a year older than my peers. It made no difference, like, in my life at all, but I was able to finish something that really mattered to me. And then the other piece was, I was really interested in development, and so I made that a focus of the things that I was going to do in my work career, and so I kept that focus. For those who have any sense that I look familiar, I was one of the Harvard medical students filmed during the Nova special about becoming a doctor. So you want to be a doctor, if that thing. If you ever saw that, I may look familiar to you from that. And actually, a lot of the things I'm telling you were things I was saying then, like I really want to help people in developing countries and so on. And so, the obvious approach to health on a larger scale than one-on-one was to think about public health. So Samantha, if you can turn off your mic. I was thinking of, getting a master's of public health, or, ultimately I got a PhD in epidemiology. But, that was a part of kind of getting a skill set to be able to do that. So if you're going to do global work, there's a lot of ways to do global work. So there are people who take off a certain period of their regular work life to go off and do international projects, and those can be quite successful and very meaningful. And then there are people who, pursue actual work in those locations to either understand better how to implement care, or to to try to uh, develop programmatic skills so they live and work and engage in those settings. So one of my colleagues here is more of a missionary person, but he was a very successful NIH researcher, uveitis specialist, and he's established an eye hospital in Ethiopia, for example. Another colleague that I worked with over the years was a very busy private practice person, but he really paired closely with Aravind, which I'll show you some slides of them in a minute, but the biggest eye hospital in the world. They provide more care than any other institution globally. And, he had a tremendous impact on how they treated people. And so that, that's private practice, just going and being there. And then you can publish from your work if that's something that's important career-wise or just personally. But that's another approach. And then I work closely with people who are part of, nonprofits. So, one of the most influential, I'd say, global ophthalmologists is Hunter Cherwek, who works at Orbis, and he, led the Flying Eye Hospital for a very long time. He has helped engage ophthalmologists in developing their skills and being able to perform surgeries and work at the highest level. And so there are a lot of career paths, and I think each of you will see mainly people like me in your training, people who've done the academic career path. But I do want to bring up that there's a lot of ways to live a fulfilling life, and don't worry about what others say. I mean, pursue what seems like the fulfilling life, not just the career that'll get you up the next rung of the ladder, I would say. So for me, I started by finding partners in other countries, and well, first off, I trained as an ophthalmologist, which is really important, and I had a good training, and I felt comfortable in my surgical skills, and I was able to have a practice that I did. But there's a big dividing point early in your career practice between taking on kind of full-time care of patients or not. And if you get into kind of a 4-day routine of patient care, surgeries, and then a day of administration, doing many of the other things becomes very challenging. So that immediate decision becomes one that may lock you in or out of certain things, unless you give up some of the clinical work later. But it's often harder to do. It's very easy to get kind of locked into being a clinician because patients rely on you. It's very satisfying. It's remunerative. And so there's all of those elements that can, if you did have these desires, can deflect you from them. And then life happens. Like you have a family, you start raising people in one place. You don't want to leave that much. You want to be there for your spouse and for your children. And so that whole juggling becomes harder and harder. And then your patients and who's going to cover you and all of that. So, and how do you fund it? Because if you're not in academics, you don't have a grant or something, then do you pay out of pocket? Finding people to pay for it isn't that straightforward. It's hard to get a paying job in a nonprofit as part-time or something like that. So for me, I then, I got my MPH and I joined the faculty. And probably if you do decide on the academic clinician scientist career, probably the only way or one of the only ways to really succeed, or one of the major ways, is to get a clinician scientist training award. So the NIH has these for both basic science and clinical sciences. And those give you this period of post-training research time and developing the career time. And I think that's a very valuable grant mechanism, and one that if you start your training, you should be thinking about if that's the career path you're going to want, if you're going to enter academia. Those awards are typically 4 or 5 years. They fund you and protect you and give you time to really learn how to carry out independent research. And then you can apply for other grants, federal grants and foundation and others. So I was lucky enough to get one of those, and that enabled me to pursue the MPH because I did the MPH and I was on faculty. It wasn't that hard to add PhD. It was a lot of work, but I could do it while I was a faculty member, and so that's what I did. I did find funding opportunities to work in Asia, so I went to Singapore and I did a PhD work there, a case control study of angle closure, and then from my perspective, I looked at the larger world and said, like, what are the areas where there's a huge public health concern, but not that much published or thought about actually how to deal with the public health issue. And so angle closure glaucoma causes about half of the world's blindness, but hadn't really been given that much attention. That's happening more and more as many of the centers in Asia become very skilled at doing their own research. But it wasn't such a big deal when I started. And so that ultimately led to a lot of epi work and then clinical trials work. And then finally, a pretty significant pair of trials that I was co-investigator on, both of which are published in Lancet, which is like really wonderful and satisfying. So that was kind of a 20-year process of getting from kind of what are the big questions to what are the studies and to getting them done. So 20 years sounds long, but I still feel young. So just so you know, you can live a long life and still feel young. In terms of other areas of living that life, one of the really nice aspects of ophthalmology is, it's fairly specialized. You can obtain a decent amount of skill and probably practice 2 to 3 days a week and still be pretty at the top of the game if you're doing that and you're really focused in a specialty. So that does enable you to do more than just ophthalmology. And for some of you, I was at Hopkins until recently, 3 years ago, and I did a lot of teaching at Hopkins. It's a great place with a really wonderful medical students. So you get the joy of teaching and mentorship and those other pieces of life that are extremely rewarding personally, and you get to see people as they reach their next phase of life and all of the joys of that, which is hard to measure, really. And one of the reasons I think for me, academic medicine has been such a great choice. Training fellows, training residents. There's so many people who come across in your life that you're an important educator for them, and it's extremely satisfying. Other things, I think I'll get into the talk in a moment, but the other thing I will briefly mention is kind of the work-life balance. It's really hard. It's harder now. When I first started, I remember saying, if I have to work on the weekends, it's just not worth it, kind of, because I wanted to be there for my family and not work all the time. And now, and evenings, initially I used to wait for during my MPH year, I had my first child, and I would wait for them to go to bed, my two children ultimately, and want to work. And I realized that was horribly self-defeating, that I was always worried about the work and not focusing on my kids. And so I stopped working at night and just worked early. That was my decision on how to handle that. But with cell phone, when I started at Hopkins, it was like $15 for 20 minutes a month or 30 minutes a month of cell phone use. I mean, you just didn't use your cell phone that much. You used it if it was urgent. With this constant ability to check email and all those things, and I just think you guys are going to all have to think about how you're going to function in a healthy way through your work lives, because it can creep into everything you do. I remember, again, when my children were young, we'd go to the Cape and there was no internet in the house we were in. So you just didn't do anything. I'd go to the library like once or twice during the week or 10 days. And now it's just like constant. It's just unbelievably constant. So that's something I just would reflect upon and encourage you to think about. The only other thing I'll say is, one of the real joys of ophthalmology in particular is the surgical, medical, chronic care. Like this, it's all there. Like I have to tell you, I mean, I'm the primary caregiver for a lot of people with glaucoma who really look to me as kind of the person they're just extremely dependent on. They have a potentially blinding condition. They really, really appreciate my help, and they tell it to me all the time. I mean, there are a lot of times where someone will say, I love you. I can't imagine my life without you as my doctor. Those kinds of things are incredibly rewarding, and you do get that in ophthalmology. I think a lot, especially if you're caring. So I think that's a wonderful part of the field. All right, so I'm going to just, I can stop there and we can ask a few questions if people want about any of the stuff that I've talked about, and then I can give a little bit of a presentation on the major global blinding conditions and my thoughts about how we could take care of a lot of those. If people have questions, I'm happy to take some now.
Yeah, just feel free to unmute yourselves or type anything in the chat if you have questions now. Encouraged to unmute.
You can also private us if you don't feel comfortable asking the question out loud, and we can ask it on your behalf.
Absolutely.
All right, well, we can save them to the end. I'll let me pull up my, just make sure I've got that working. Get my talk going. Okay. So, you know, as I said, I've done, everybody's seeing this correctly, is that right?
Yes, we're seeing
Yes?
this correctly.
Okay. So as I've said, you know, one of the things I do think a lot about is why are so many people still blind in this era? Because we've had pretty good solutions for a lot of the blinding eye conditions for a long time. So I'm going to walk through that. If you think about why we have system failure in so many aspects of health, one of the biggest ones is maldistribution of wealth. And one Nobel laureate pretty much in economics won that for showing that famine really doesn't happen except in maldistributed societies. You know, there's almost no reason to ever have such a thing. And so that's what you see when the wealth is accumulated by too many people. Also, blindness is often a low healthcare priority. When you look at global discussions of development, it's child mortality, maternal mortality, things that kill you, not blind you. A lot of places are poorly managed. And if you think about, I've often thought about this, you know, if a third of the taxes that were supposed to be paid got paid, we'd all be fine, like we'd have roads and police and there'd be no issues. And if everybody managed organizations well, there'd be very little blindness. Personnel are not totally adequate, not adequately trained. There are some situations where the technological solutions just aren't there yet, or they're there, but how to implement them isn't clear. And a lot of times our diseases of the eye don't cause symptoms until it's very late in the disease. So that's a major cause of blindness. And then there's this almost immeasurable thing, which is a sense that as I age, I go blind and kind of this is my life and it's the will of whatever, that this is how it should be. So I think these are all important drivers of why so many people are blind globally. And then there's, you know, other barriers for institutions. You know, if you're in a governmental institution, or many of us even, you don't fully control your staff. There's a problem in some instances where the profits that could stay in eye care leave eye care and go to support other systems, so you don't get growth of eye care, which would be nice. And there's, you know, a lot of competition for physicians, particularly in poorer countries. They can make a lot of money treating the wealthy. They can go out and work for the Clinton Foundation or somebody else. They don't have to stay in eye care. So a lot of times you'll see ophthalmologists either not showing up or showing up very briefly for their government jobs and then doing other jobs that pay and take care of their families. Human capital just seeks other work. So if we look at the causes of blindness, you know, for a long time, people didn't look at refractive error as a cause of blindness. We would get population-based prevalence surveys that would only look at, you know, blinding conditions, not refractive error. But that's kind of crazy, because then you forget that refractive error is such an important part of it. So if you look at just the top three, they make up, you know, 60% or more: cataract, refractive error, and glaucoma. And there's a lot of others in there, obviously. And, you know, some of them, like corneal blindness, could be lumped and joined in and make up a bigger piece of the pie. But these are the elephants in the room. And if you get rid of refractive error, then you're talking about mainly cataract, glaucoma, some AMD, some diabetes, and so on. So just in terms of the lack of even distribution, if you look at this, these are Gini coefficients, which if it were perfect, if you had a perfectly even distribution of all wealth, it would be 0 or 1, I forget. But if it's maldistributed and somebody has all the resources, it would be 100. And you can see there are some that are like 70s, like South Africa, where there's a lot of wealth, but almost all of it in the hands of a few people. And Canada is obviously a little better than we are, and the Nordic countries are as well. But a lot of the big swaths of area where there's a lot of poverty also have tremendous maldistributions of wealth. And if you look at the GDP per capita in US dollars, this was in 2014, but you can see, this isn't bad down here. It's just that it's all in the hands of some. And you can see that even within Africa, there's tremendous variability, right? So in these sub-Saharan countries, it's really not good. And I've done a bunch of work in those locations trying to improve eye care service delivery. And it is possible, and people can afford to pay for eye care services because they're not that expensive, but it's hard when you have severe poverty. Lack of political will frequently leads to poor health outcomes. This is a really nice website called Gapminder. And what it shows is, if you're Vietnam, Nicaragua, Palestine, people are living pretty long compared to their income. But if you're South Africa, your mean life expectancy compared to your overall income is quite low. And this just gets at the idea that, we could do a lot more given the wealth, and some countries do a lot more with their wealth. There's a great article, and one I'd strongly recommend. I like Atul Gawande's writing a lot, particularly the New Yorker articles he's written. And he wrote one recently about Costa Rica and how they take care of people from a healthcare perspective. And that gives a sense of why some countries are much better able to provide for their populations than others, despite low incomes. So most blindness is either cataract. You can see very dense cataracts in this woman. It can be refractive error, which is globally just an increasingly large problem responsible for billions of dollars in unproductivity, lack of productivity. And glaucoma, which is damage. This is a fundus photo inside of the eye of the optic nerve. And normally there should be healthy tissue here, and you're just seeing mostly white, which is loss of. So for these major conditions, there are some common themes, but each has its unique challenges. I'm just going to go over this. So let's say for refractive error, it's estimated, we're talking about 150 million almost, who have vision that's really suboptimal solely because they don't have a pair of glasses globally. And, a bunch of people that it worse than 2,400, so basically blind because they can't wear glasses. And there have been economic analyses that every year we lose hundreds of billions of dollars in productivity because of this. And it's really simple. If you think about the process, so one of the things I realized as I became more interested in research, and there's a few important lessons. One is doing a research study is very similar to fulfilling a business plan. You come up with a budget, you contract for what you're going to do, and the idea underlying a research, particularly clinical research endeavors, is often not rocket science. It's not like you're the only one who ever thought of it. But a lot of the reason you get it done or one succeeds is to pursue it until it gets done. So for example, with these refractive error studies, I've done several what I consider pretty important studies, and they're not shockingly different from what you or any of you would have thought of. And I'll show them to you. But basically all you do is you refract, which means figure out what the glasses needs are. You measure how wide apart the eyes are. You pick frames that people like, that will last, that are well made, and you provide the glasses and make sure they fit. That's it. So we're talking about hundreds of millions of people without glasses for this reason, for these 4 steps, which can literally take almost no time at all. So some people initially in the late 90s thought, we'll create these Harry Potter round glasses that are filled with silicone, and you'll inject the silicone and the shape will mold, and then you'll have the refraction. And you could do it yourself. You could dial it in and lock it in. But if you think about the engineering of this, like the silicone bleeds eventually, they're heavy, they look stupid, nobody's going to use these. But that was at least the initial thought. And that got a lot of attention. Then there was this, which you can kind of almost see yourself. These are kind of cloudy looking, right? It's based on a wonderful principle of, if you think of a saddle on a horse, you have two saddles, they slide against each other, and you can get all kinds of refractive ranges, but it's just not going to work. And they show it almost like sexy to wear these glasses. So how do you market? How do you make it happen? And then there was this company, Vision Spring, which is a really interesting story. All these stories are always so interesting. The founder of Vision Spring did get an MPH at Hopkins, and he set aside $1 for like 10% of his profits in a very high-end optometric practice in New York City. And that led to this. And ultimately, a bunch of people from this group became Warby Parker. So it's really interesting to think of like how these things get to be. But the idea is, if you just need reading glasses, which are so easy, you can source them for $1. You can give somebody who's an entrepreneur in the town $1, and you get $1. And then for $3, you've sold glasses. You can maintain your whole operation. And they've gotten into more stuff, but that's a very nice idea. And we thought, well, that's out there. Why don't we try this for all of refractive error? Maybe we could come up with simple prescriptions. And so the initial try was ready-made spectacles. So just for you to understand, for a pair of glasses, you can correct just the basketball shape of the eye, which is the roundness. Or some people have a football-shaped eye, which is what we call astigmatism. So that kind of a pair of glasses needs some special creation to make it perfect. But you could say, forget about the football shape. We're just going to give you round glasses, and they'll do pretty well for almost everybody. The nice thing, if you have ready-mades, you just make them, and then you can hand them to people. So they're available the same day, probably a lot cheaper, and you can just use the best sphere. And then an improvement on this that I'll just mention is you could have a lens that you pop into each eye, and that would be, each eye would get the best sphere. But in this study that we actually did in India and China, we just used the same glasses for both eyes. So we didn't optimize for both eyes, but we used the same one for both eyes. And it was, a double mask study. In India, they were adults. In China, they were adolescents. And they were really well tolerated. So if you look at the ready-made spectacles, 90% of people plan to keep using them. Customs was better. A few needed them remade, and you could figure out who they were, the high astigmats and things like that. But people were wearing them to the visit, and they kept them. So this works, and this is an option. And everybody had improved vision and better overall, and they were willing to pay almost the same amount rupees for these. So, you could just set up a program that just does this, and with the pop-ins, which are now available with nice frames, this would work pretty well, I think. And we had similar results in Chinese children. So one of my friends who had been a Marine started doing, he was distributing glasses as a Marine in Mexico or other places. And he said, this is just inefficient. And he came up with this very neat system, which is basically each of these little areas that you see are changes in refraction. So as you're rotating it through, there's a little hole here, and the person's looking through a slightly different refraction. And when they get to where they see clearly, they stop. And so you just need this little kit to do a refraction for each eye. And when they're done, you go through that. And then when they're done, there are these color-coded things that you pop into the frames, and you've distributed your glasses. And that's a very nice way to do things. And there's obviously some limitations, but if this could be fully implemented successfully, it could lead to extremely cheap glasses, because these frames aren't that expensive, and you could distribute them same day very quickly with a small backpack. And this just shows how it can all be packed into that. And this is somebody wearing the old terrible ones. This was a researcher who's still at Hopkins, Varshini Bharadwaj. And this was just showing the nice pop-in ones that you could get out of this other system. But you could even remove the person who measures the glasses who's not the person themselves. So we can use what are called autorefractors. So this is an autorefractor that, they had originally said they were going to sell it for $1,000. It probably could be sold for that amount in high volumes. And it gives you the answer what the person needs, exactly what they need. And then, let me just skip that. I thought I added a slide to this. Well, we did this in India, and we based the glasses that we gave patients off of this, or off of meeting with an optometrist. And the results were that people liked them equally well. And so you could basically just do this and not have an optometrist in the mix. So the way to think about development is to try to avoid manpower or woman power that you don't need. And this would be one way to do that. When we go to school-based programs, there's a lot of non-wear, so you can't just distribute the glasses. You have to think about ongoing wear. Think about it like a medicine that you're giving people and that they need to continue to take, and how do you do that? And then ultimately, who's going to pay for these things? So if you can drive down the cost, it'll help make it possible, but that's a whole nother area. So I'm going to segue to cataract briefly. This just shows the GDP per capita and the number of cataract surgeries per million people. And right off the bat, you should say, wait a minute. Cataract surgeries per million people. Well, if I'm in Japan, I'd expect a lot more cataract surgeries than if I'm in Zambia, where the population distribution is completely different, right? You have very old people in Japan and very young people in Zambia. And so this isn't a great number, but it's the one that people use just to get a ballpark sense of how many surgeries people are doing per population. But if you look, there are some places that do incredibly well, like India. And there are some places that do really badly. This was 2009. So, China, South Africa, China's moved way up this curve now. They're doing a lot more surgery because they saw this and they've changed what they do. And then there are some countries that are just, doing tons of surgery because they have the resources and desire and enough doctors to do it. So is the reason too few ophthalmologists? In developed nations, it's about one ophthalmologist per 10,000. In Africa, there are places where it's like one ophthalmologist per million. That's a pretty tough number. It's pretty hard to get all the work done when there's only one of you in a million population. And then there's distribution. You're a well-trained medical doctor, and we see this in the United States. You're well-trained. Do you really want to go to rural wherever to raise your family, or you're used to training in more, cultured or more at least varied communities? It's hard to get people in these poorer countries to move to less populated areas. Cataract surgery is pretty straightforward. This is showing one approach. You can see this very small incision here. This is a huge lens. We're now able to take out that huge lens through this pretty safely without any instruments. You just need a knife and not any mechanical instruments. And that's called manual small incision cataract surgery. And so it's not really that small, but it's a big improvement over older surgeries. And this just shows, somebody doing just that. And there's more complicated ways to do it, which is the way we mostly do it, which is to melt the lens in place with this device and remove pieces through this device and use a very small incision. You can see how small that incision is. That's called phacoemulsification cataract extraction. And in that instance, you fold the lens into a taco because the incision's so small that the only way to get it in without making a bigger incision is to fold it in half and then drop it in. And this is where it sits in its natural location inside the bag that held the old lens. So Aravind decided, we really should do more surgery. And one way to do that is to get more productivity out of our surgeons. So this surgeon will operate on this patient, one scope. He'll clean his hands a little bit in between cases, won't even change gloves, and he'll go over here and do another operation. And this was an unbelievable innovation. And surprisingly, although not that surprisingly, infection rates are as low, if not lower, with this approach than with the usual approach that we have. And in fact, during COVID, they stopped doing the same room stuff and changed how they did stuff between cases. And the infection rates were no better. They were exactly the same. They just published that. So this just shows a little bit of how it's logistics more than anything that's going to solve a lot of these problems, because in this instance, you've more than doubled your surgical volume because you don't have to wait at all while this person's rolling in and out. You're operating, and these people can do over 100 surgeries in a day. My typical half day is 5 or 6 surgeries because of turnover. And this just shows, the beautiful settings in which these people carry out their work. Cataract programs are very profitable. It's a very positive experience for the patient. You can offer tiers of service. You can offer more, better quality or some slight benefit like small incision versus phaco. You can charge people more for the phaco and generate a lot of money. And scaling up is happening. And, Africa is still quite difficult, but starting to improve. These are just examples. This is in Nigeria. This is in Kenya. This is in Ethiopia. These are all hospitals with which I've worked. This is also in Kenya. And this is in Zambia. And these are all kind of unique institutions that the Hilton Foundation gave us some money to work with Aravind and try to help these places expand their quality and quantity of services. And so that's, again, just pure logistics, but helping to improve. There are people who fly in and just do a bunch of surgeries in regions where nobody else is doing them, which is a practice that can be discussed for hours, whether that's overall a good thing or just temporarily a good thing. This was an effort to try to establish strong centers domestically run locally by people who were creative and could expand their services once they succeeded. This is another one in Nepal. This is a beautiful one. I visited this and worked closely with this institute. They're in Chittagong, Bangladesh. But the founder, and you'll find in many of these institutions, there's a tremendous, wonderful human being who is the founder. The founder had a very artistic bent as well. And this is just showing a lens looking into the eye and how the rooster is upside down and how the eye inverts images. I'm going to shift gears to diabetic retinopathy very briefly. Diabetes is a huge issue. Enormous numbers of people with diabetes, and a lot of them get eye disease. This is proliferative diabetic retinopathy, where you get neovascularization and they bleed and it's bad. This is macular edema, where you get swelling in the center of vision. And you can just see that the developed world is having a massive growth over the next 30 years or 20 years, and developing countries even more so. And it's interesting to go to developing countries and see the amount of obesity that is now prevalent. This is an interesting slide. It basically gives you the numbers in millions in 2007 and 2025. And so the increases just everywhere are astounding. So diabetes is a tidal wave of blindness waiting to happen. Why families need screen TVs. So when you screen for diabetic retinopathy, you need to screen about 20 people to find one who needs a laser. Has to happen over and over, and it doesn't restore lost vision. So this is an incredibly challenging area, right? You're going to treat people, they're not going to feel happy about your treatment. Are you going to charge them for this thing that they didn't even see a benefit for? How do you fund these programs? Basically screened all of them and you found a few, and yet those people have to come back again and again. And we know that there's retinopathy present in everybody, and there's vision-threatening retinopathy in about 10% when we screen. So we tried in this Chittagong place to develop fundus photography and monitor the process, but it was really hard with all the infrastructure. And I think the real advance here and what's going to change your lives dramatically is all of this AI, right? That right now I make diagnoses, I make decisions about who's getting worse based on looking at the data and kind of summarizing it in my mind. I bet that in 5 years, I won't be doing that at all, really. The machines will tell me, and I'll be just double checking that it doesn't seem insane. And then I'll be talking and integrating that for the patient is how it's going to work. So if you're thinking of ophthalmology as a great differential diagnosis field, maybe in some parts, but not many, I think it's all going to be done for you. But I think that's true everywhere. The FDA has approved now two diabetic retinopathy screening machines. These are completely self-diagnosing. So all you need is somebody to push the button, take the photo, and it will tell you what's going on. And what's really important and exciting is recently Medicare came up with a CPT code and it pays. So now there's like $55 that comes in when you screen. Before it was almost impossible to get paid for your screening. And so now it'll happen as opposed to before when it was unreimbursed. So just in terms of diabetic retinopathy, it's on the rise. We have to do something. Obviously, you want to prevent DM and DR, but implementing and maintaining a successful program will require substantial investment. Glaucoma is a really tough one. It's chronic, it's slowly progressive. This is an optic nerve that's missing its rim tissue here and somewhat here as well. And you can see the missing vision. This is the nose side, very dense area of missing vision, and another dense area. This is your blind spot that we all have. And glaucoma is largely irreversible and asymptomatic. This person probably wouldn't know they even had this missing vision. It's only when you get here that you notice that you're missing vision. But there are deep learning networks that are starting to be able to identify glaucoma on photos. This is severe glaucoma. Anybody, my dog could recognize this probably, but later on, it'll be able to distinguish more subtle forms. Angle closure is a thing that I was most interested in. We do put little holes in the iris in some people, and we did a very large study to see if it's beneficial to do that. This was in Guangzhou, and we compared. We showed that it wasn't all that beneficial to do the iridotomy. And this is a very important study looking at whether if you just take out the lens, do you do better than doing an iridotomy? And the bottom line is you do. People overall had a higher satisfaction quotient, better pressure control, better outcomes. With open angle glaucoma, the problem is it's eye drops, lasers, surgeries. None of these is a definitive treatment. So trying to deal with glaucoma when you identify it in developing countries remains an enormous challenge. For that reason, it's often not addressed in global planning. So we're going to need a better treatment paradigm so that developing countries will find it worthwhile to screen for it. So right now, the main focus is at centers where people come in and they're getting care to treat their glaucoma, but very little on screening. I just thought I'd give you some of the exciting, fun stuff that has been huge in terms of its global impact in a few slides. Trachoma is a disease of chlamydial infection of the eye. It causes scarring of the eyelids. And this is an example of why this happens, because flies are very common in some areas. This is really an example how they like to feed off this stuff and are on the face. This is showing the trachoma on the underlid. This is a beautiful photo of this woman or girl, and then she's treated, and look how much better she is. And trachoma is just one of those terrible illnesses, but it's almost eradicated. And that's largely through improved public health as well as public health efforts. We still face the problem of lids turning in and damaging corneas. There's still room for a lot of surgery for these people to improve it, but this is a disease that's on the wane. This is the healthy conjunctiva with the beautiful vessels. This is a trachomatous infected conjunctiva that's been scarred and is not doing well. More permanent scarring. And it's, this was in 2004, and that's final scarring and damage to the cornea. And so with water and distance from water, you don't get face washing, you don't get cleansing, and getting water there has made a huge difference for a lot of these places. This is a face washing campaign. That's one of the great efforts that's been done. There was actually a randomized clinical trial done by Sheila West, who's at Hopkins, to show that face washing is effective at curing or reducing trachoma. And then there's ultimately the safe strategy, which is surgery, antibiotics, face washing, and environmental change. Vitamin A deficiency is another really interesting one. Al Summer, who was the Dean of the School of Public Health and is really one of the most impressive investigators in ophthalmology. There's a drying of the corneal conjunctiva that's called the Betos spot, which is a bacillus infection. And then you get drying of the cornea, so it almost becomes, you get metaplasia of the cornea, so it becomes almost like skin, and eventually it can melt. And that can lead to perforation and blindness. And you see that here in this girl. And what Al discovered was that these kids in his study who were vitamin A deficient were dying at higher rates. And then he figured out that if you supplemented, they wouldn't. And that led to a tremendous reduction in early childhood mortality globally. I gave this talk to a dermatologist in the Uniformed Health Services, and he collects these stamps. And I thought this was a pretty beautiful stamp showing it. And all it takes is a little vitamin A and it goes away completely. And that's what's been done. I'll end with onchocerciasis, which is a worm, a nematode, and it's passed by black flies who transmit it by biting you. And this is the Simulium damnosum, the damn black fly. And it leads to these worms that form in nodules in the skin, which produce the little worms, the microfilaria that cause the disease. And you can see them here in the skin and in other parts of the body. And they lead to ultimately severe corneal scarring. When they first started the onchocerciasis control program, they started in West Africa, and then it's extended and still active in this part. And it's more or less eradicated this. This is what onchocerciasis led to. So not only is this young man blind, but the child has to walk him around. If you go to the World Health Organization, this sits in front of it as an example of public health ending an unnecessary blinding condition. So major lessons.
Hey, thanks for your time.
I'm sorry. Hello? Okay. Major lessons from global eye care that I'd like to have you take home. A lot of people are needlessly blind, and most of these conditions are treated easily. It's mainly about implementing known treatments, except in some areas. And really, to succeed, there needs to be a political will and leadership to make these things happen. The technologies will definitely make it easier and make our reach much wider. And we need to be more skilled at translating the improvements in care from developed to developing countries. For example, with intraocular lenses, it took about 20 years after they were widespread in the United States for them to make it to developing countries. And I'll end there and stop sharing, and be happy to discuss with you any questions anybody might have.
I have a quick question.
Yeah.
Hi, so I'm Tara Bijan. I'm at MCG, Medical College of Georgia, and I'm an M1. And I was wondering, so you talked a lot about the different grants that made these opportunities possible. Do you have any recommendations of grants that medical students can apply to if they're interested in starting like public health projects?
So there are, depending on sort of, there are always some specific ones for certain groups. So you always want to look for those if you fit into any specific group. There's things like Fulbrights that you could take a year off and do. There's often organizations that you could work with that might find a way to fund you briefly for a year to work on some projects with them. I think those are, as students, you don't need that much money. The Doris Duke Foundation has specific institutional grants, and you have to look up the Doris Duke institutions, and you can apply through them, I think, even if you're not part of that institution. So we had students go to different countries off Doris Duke grants. Yeah, that's off the top of my head, but there are monies. And, to be honest, it's nice when you're as young as you guys are that your needs are much less, right? You're not maintaining, a bunch of houses, a whole house or other people, although debt is always an issue.
Yep.
Yeah, sure. Somebody texted in, how might the future of AI shape ophthalmology? Well, I think it's going to transform it completely. So, a lot of what we do in terms of routine care will go away altogether. Like, there's just not going to be a lot of reason for me to see a diabetic for routine care. They're going to go to a machine that tells them. And for a lot of glaucoma, which is my specialty, my guess is that you'll go to a testing center, and in the testing center, you'll take a bunch of tests and it'll say, you better get seen or you're fine. Come back in a year, 2 years, 3 years, it'll be much more precision. DNA is going to play a big role in that. We understand there's over 120 genes identified for glaucoma now. They're not highly predictive, but they're combined could tell you a lot about a person. We'll have the genetics, we'll have the testing, and we'll know totally different ways to approach people in that regard. Right now, the biggest reason for a lot of retinal surgery is the failure to manage diabetes. I would imagine that we will become much better at that with these AI devices, so surgical rates will go way down, is my guess. I mean, there's a lot of things that are going to change. Cataracts will still have to come out physically. Somebody has to take them out. Given the rise of diabetes, do you think diabetic retina will be the main area of opportunity for global? I've thought that for a while, actually. I've, you know, when so part of my career that I didn't talk about is I did get funding to help organizations just because I was really interested in it. Initially Orbis International, and then Helen Keller International, with whom I worked for quite a while as a paid consultant. And they paid through Hopkins, so it wasn't money in my pocket. It was just a way to pay for my time away from the university. But we were focused on diabetic retinopathy for much of that time because, again, like these cataract issues, there's some training concerns and otherwise, but managing chronic illness that needs repeat visits is a big challenge. Somebody posted an opportunity that people can apply for other research, which I think is always good. And it is true that a lot of institutions have institutional grants for people. I mean, I'm the head of glaucoma at Mass Eye, and I'm fundraising to try to have funded research positions with us. But you know, there's always people have grants and things. So if you reach out to investigators, you can often find something that way if you want to take a year off or time off. A lot of people do that nowadays, given the competitiveness of the ophthalmology match. Anything else?
Dr. Friedman, I had a question for you.
Sure.
So with, you know, the onset of COVID, we've seen that certain global health systems where we have people travel to different countries and do surgeries has been a little less possible. I know Orbis kind of went on hold during this period. What do you see as sustainable ways for communities to kind of from the ground up have their own operations, you know, without relying on people to come in and do these surgeries?
Yeah, so there's a bunch of things. I think, you know, it's a little controversial, but I think, you know, Africa actually has countries where they have cataract surgeons. And if cataract surgery weren't on the human body, it would be done by specialists who just did that, right? It's not like you need an MD or a PhD to take out a lens. It's a procedure that is reproducible, that has very little medical knowledge that's required to do. But we retain it in medicine, even at places like Arabic, because I don't know. I think it's part of what makes us doctors and so on. But a rational world, it would be like, you know, making widgets and you'd have a widget maker, you know. But in terms of your question about like training, so there's multiple things that are going on that are going to make training much easier. One is the development of very high quality, low cost robots that you can practice on, right? Simulators, robotic simulators. And so our residents are much better than I was on their first 20 cases. They are. I mean, they do a lot of sim and they get real feel for the eye before they're even in the eye. And Orbis, so by conflict of interest, I'm on the board of governors of Orbis International now. It's a non-paid position, but I do care about the organization. And they're developing a low-cost version of that. There's, you know, even with 5G, you can do live high-def surgeries. So that we've had remote coaching where, you know, somebody in my chair can watch somebody in Uruguay do a surgery and help them to do it better. So I think that's going to happen more and more. There are also, you know, what people term south to south collaboration. So it's very easy to send an expert to a poorer region of India to help another Indian ophthalmologist. And there you avoid a lot of the licensure stuff. And there are a lot of very talented physicians in every country. I've always thought it was a little elitist or ridiculous to assume that there weren't. So, you know, I do think people learn a lot from seeing other systems and coming and visiting with you and spending time. And when you go there, you provide a lot of insights because you come from a different place. I learn when I go and they learn when I'm there. So I do think those things are still very important and meaningful. But I agree. I think national borders are becoming less permeable. You used to be able to fly into India and operate the next day. Now you have to be licensed. That's true of most countries of the world. So I think that whole model, that whole business is going to have to change. And just to get at the developing capable, so one model that we worked on, I worked for almost a decade in sub-Saharan Africa at those hospitals, is to find people who have the initiative to get going and then really support them. because if you help build one Aravind, hundreds of millions of people get treated. And if you can find a handful of really competent people that are ready to go, they'll develop these centers of excellence that will then become the beacons of hope for those areas. So I think that if I were investing my efforts, I think I was a little more loose and would just go place to place and help different institutions. I actually think, in retrospect, a more rewarding life would have been to stick with a handful or one or two great institutions and help them be greater, because I think they really do a lot more than you'd think once there's that kind of synergy internally.
That's great. Thank you.
Yeah, sure. There's a couple in the chat. Let me just look. So the implementation question was, did I pursue any additional Lean Sigma or any of that stuff? I'll tell you how I got my pseudo MBA, and it was with this group of African hospitals. They came and Aravind had us watch every aspect of how you do eye care, and then we'd go in the field and see it implemented. And so that gave me a sense of how organizations work. But the other thing I did, and I think you should all do this throughout your life, is visit other people whenever you go anywhere to see how they practice, because you'll see many ways of practicing. And the other piece is to be very open to new approaches, because you need to be to get better over time. So, I've probably been, with my work through Orbis and my work on systems, in 20 plus, maybe 30 hospitals that I've evaluated in some way. So I feel now as an expert, just from almost like an apprenticeship. But you could do degrees, and I think an MBA is a great degree if you want to do development work, or such a thing would be very helpful for development work. The other question was related to the epidemiology. I really think epidemiology is changing a lot. It's become more focused on bioinformatics, on like, we know the basics of most diseases. So it's like the genetics and how the genetics influence a disease, a lot of more of that. Really learning new epidemiological information is harder and harder, I think. And so for me, I've shifted more to, personally, more to clinical trials and to implementation research, because that's, for me at this point in my life, where I think I can make the biggest impact. One or two more in the chat. Let's just see. Yeah, everybody should feel free to leave. I don't think I think AI is going to change the world for all of us in many important ways, and we are going to have just less of that, wow, what a great clinician mind you have, because I think that'll be true in all fields. Because I'll give you an example, and it's an obvious one. It's one that everybody uses. But when Google did its AI on the retina, it could determine with 99% certainty if you're a man or a woman. I had no idea, like none. I was looking at retinas my whole career, and I had no idea that there were male and female retinas, none. And age within a year or something like that. It's crazy. So we're never going to see the things that these machines see after learning on tens of thousands of them, which they can do very quickly. So I think all fields are going to face that, but I do think that being a doctor will be not just procedural, because the machines can be wrong. There's also, how do you use that information? So that this patient has a 10-year risk of developing moderate vision loss. And you could reduce that, but do you do it this way, that way, or another way? Nobody's going to tell you those things. There's still going to be a tremendous amount of nuanced decision making, and then how these things are employed in a widespread fashion so that they help people is going to be really important as well. There's a huge potential for like disparities in this area as well. We already know that facial recognition is fairly racially biased. A lot of this stuff needs to be thought through, and I think I think every era felt like it was all over, the machines or this or that. But we do get more and more specialized, but I think this will allow us to be better at all the decisions we're making.
Awesome. I think there was one question in the chat just about why you think the MBA is good for development work instead of an MPH.
I didn't say one or the other. I just think, like I said, I think so much of this is how do you motivate organizations to do what we already know? Like, I think a lot of development is understanding human nature and figuring out the incentives and working it so that people really do what needs to be done successfully. And it's also quality control and purchasing and stocking and making a profit so you can treat the next person. I mean, that is all a big part of being a good and successful organization. So I'm not saying you should do A or B. I'm just saying it's perfectly reasonable to consider that as a way to grow into that field. One of the reasons I liked ophthalmology for global blindness, because somebody had asked that, for global work, is there still is an unbelievable lack of eye health in the world. And also there are these procedures that you can develop, think about, and implement differently in these settings in a way that'll work. And then on top of that, to do global work, you have to be away from the office for some periods of time. And it's a kind of job where you actually can be away from the office for periods of time. People can cover you and take care of things. So it had all those pieces for me. And the other thing is, it's so, like, the people are so happy afterwards, I mean, it's just incredible the impact you can have on people. I remember asking this woman in Kenya, so how do you feel today? And she started she was like 88 and like bent over, sitting on a bench. She just had surgery the day before. Her vision wasn't perfect. And she got up and started dancing and clapping and singing with her friend. I mean, it was just unbelievable. It is unbelievable. So, it's very rewarding work.
Absolutely. And then those all those diseases and the current needs that you went over in your presentation, would you be able to maybe compare those needs in ophthalmology to work in other specialties like gen surgery or medicine?
So I think that, again, like gen surgery, there probably are tremendous needs with like laparoscopy and newer techniques for doing things much more safely. So I think gen surg has a huge need in developing countries. There just aren't enough trained. There is a lot of trauma, and so I would argue that that's an area where you could have a huge impact. The other areas, they're very specialized, like ENT. Yes, there are cancers, and yes, they're very important. And hearing loss is huge, but most ENT don't focus on just hearing loss, except for very rare cases that need, special surgeries to improve them. Maternal and child health always seemed hugely important to me because that is such a big part of survival and health for people. If you could improve that, you could have a huge impact. I thought seriously about maternal and child health, being an OB or something, because I was interested in global issues. But it's hard to compare. I don't know those fields that well. I don't know what people are doing in those other areas.
There was a question from an M3 that came in that was wondering if you could provide some advice for someone who is an M3 and learned about their interest in ophthalmology very late in the game and wants to know what you recommend they do to kind of amp up their resume and get prepared.
Take a year off. You're gonna have a much harder time. You won't succeed as well in your match. I mean, now that I'm on a residency selection committee, I can tell you, and I don't mean this at all in like a scaring way, it's a very competitive process, and there's a lot of very capable applicants. So if you just decided at the end and you really don't have any eye something or another, and nobody in ophthalmology to write you a letter or somebody to write you a somewhat lukewarm letter, it's just not going to bring you up in the process. Like, you may have like really beautiful background, you may have done great things, but it's really hard to overcome that these days. So I think, if you really want to do eyes, it's probably worth the year, and it'll be an interesting year. You figure out somebody to do something interesting with. It's a growth year, and then you can apply.
Just to the person who asked that question, anyone else who's also in a similar boat, that was my position last year, and I ended up taking a year off. So I'm happy to talk about that. It's been the best year of my life so far, no regrets at all. And that was kind of the inspiration for this program, was to help first and second year students learn about ophthalmology a little bit earlier in the game, so you're not forced into a research year.
Right.
But happy to answer any questions. If you want to reach out, I'll put my email in the chat.
And I think also to frame this conversation, like, yes, I think like the field is super competitive, and that's something to be mindful of. But as you know, during Dr. Friedman's talk, like there is so much excitement. There's so much excitement from you all, and promise in the field. So we're all rooting for each other and rooting for you, and the future of ophthalmology.
Yeah, so I used to, I was the advisor to medical students at Hopkins for almost a decade. And I would always tell people, just pursue what you're interested in. And I really felt that way at the beginning. And like, it doesn't matter if somebody just asked you, you have to do research in ophthalmology and blah, blah, blah. I used to say it doesn't matter at all. I think that's changed, unfortunately. We live in this kind of world where there are a fair number of people who have done those things now because of just this people getting prepared for that career, so that when you don't have them, it's not impossible, but it's harder. And so, I think, you should, if you want to do ophthalmology, at least in the current environment, really plan what your application is going to look like to try to make it the best application it can be. That's what I would recommend. And I do want to say, just as Nathan said, I agree. I initially said yes to doing the residency because I felt like I was being asked and I should. It's an enormous time commitment to be an interviewer for these things. It probably took a week of my year because I had to read through a lot of applications. There are hundreds of applications, and then I have to read through the final 50 who get interviewed, and then I have to interview all these people, and it was just an enormous amount of work. But I felt so optimistic at the end of that. You guys are going into a career with unbelievable people who really have a very optimistic and positive outlook. I was amazed by the people I met during that process. So, and I'm hoping you guys will be the same. That's one reason I agreed to give this talk. I think it's a great time to be an eye doctor. I'm not trying to discourage you. I think this is a wonderful time to be an ophthalmologist. And I would do it again for sure. And not all roads are straight. Look, I did East Asian studies. I was a little older when I started. It's okay. It's okay to have different, America is very nice that way. A lot of countries, you're already assigned your MD at 16 or whatever, and that's it. All right, well, thanks a lot. I really enjoyed meeting you all, and hope I see you on the interview circuit. Have a good night.
Thanks so much, Dr. Friedman. Appreciate your time.
Bye-bye. Sure. Bye-bye.
Take care.